My name is Betty White. I'm a nurse practitioner from Digestive Health Specialists, and I've been asked today to update you on some basics about what is IBD, or inflammatory bowel disease. So inflammatory bowel disease is basically two distinct diseases that sometimes overlap, and those diseases are Crohn's disease and ulcerative colitis. These are immune-mediated diseases. We don't know the exact cause of these diseases, and there are differing opinions on what may or may not be designated as inflammatory bowel disease. So Crohn's disease basically affects the large bowel, small bowel, stomach, can affect anywhere from the nasal passage to the rectum. It's primarily about 75% small bowel disease. There are people that have a combination of small bowel and large bowel disease, and some people just have a small amount of rectal disease. It's patchy, it's not consistent through the colon, and it typically has symptoms of abdominal pain, can have changes in stool pattern, and rarely has blood in their stool as a diagnosis or as a symptom. Patients with ulcerative colitis, on the other hand, have bloody stool as their major symptom, and rarely do they get abdominal pain or other symptoms with that disease. And sometimes it's hard for us to distinguish one versus the other, and so we have this overlapping name of inflammatory bowel disease that we use for these processes most of the time. In ulcerative colitis, the disease itself affects the large bowel. 30% have what we call left-sided disease, which is primarily in the rectal sigmoid area. 30% have left-sided disease up to the transverse colon or below. And 30% have what we call pancolitis, which means it's throughout the entire large bowel. And interesting enough about ulcerative colitis is the amount of disease that you have doesn't always confer with the amount of symptoms that you have. So sometimes you have a lot of symptoms when you have very little disease. So those are the two specific diseases that we are talking about. Now sometimes it's interesting that people will say, well, I've been told I have IBS, I get stool changes and I have abdominal pain, but I've never had pathology that's told me that I have a disease, and that's a different disorder, and sometimes it can be confusing between IBD, which is inflammatory bowel disease, and IBS, which is irritable bowel syndrome. IBD is a diagnosis of biopsies. So there's several things that your provider may do, and one of those things may be lab tests. You may be scheduled for a colonoscopy or flexible sigmoidoscopy. You may be scheduled for an x-ray, like an MRI of the abdomen or pelvis, or a CAT scan of the abdomen or pelvis. Or you could be scheduled for a capsule endoscopy, in which we have you swallow a large pill, which is a camera that tumbles through your bowel and takes pictures for the doctor to review. But there are several different ways, and a lot of times it takes a lot of these different exams for us to be able to confirm the diagnosis of inflammatory bowel disease. There is no, again, cure for IBD at this time. There are several good medications that we can put you on to put you in remission. And I think the most important part is if you do have inflammatory bowel disease, the point that you take your medications on a regular basis is probably the most important thing that you can do to keep yourself in remission, because otherwise you have flares of disease, in which can cause complications with anemia, dehydration, abscesses, infection. So really the most important part is taking your medication on a regular basis. There's no specific diet for inflammatory bowel disease. In fact, many of the diets have not been shown to have any help with inflammatory bowel disease. But there are diets that are that people have found to be somewhat helpful with symptoms, although the diets don't cure disease. And many of those can be found on different websites. We typically refer people to the CCFA website, ccfa.org. That's Crohn's and Colitis Foundation of America. They're a research nonprofit group, and so I think they have really good information. Several different medications can be used in inflammatory bowel disease, and some of these are medications that have very little risk or very little side effect to them, mesalamine being one of them, and it comes in several different forms. I think there are 7 different forms available commercially in the United States. And these medications are pills that are taken on a regular basis. They can also come in the form of a rectal therapy, maybe a suppository or an enema as well. Then there are medicines like what we call immune modulators. Those can be things like Imuran, azathioprine, 6-MP. These medicines come with more risk, and definitely these medications need to be evaluated with blood tests on a regular basis, and these medications should never be taken without a discussion about risk and benefits with your provider. We use steroids and antibiotics, although those things are more for short-term to get the flare under control. We don't use corticosteroids on a long-term basis. And I would say the most important thing if you ever are on steroids is that you take vitamin D and calcium supplement along with that. And there are recommendations on websites, the AGA or CCFA again. And then there are medicines like biologics, and biologics include medicines you might have heard of the name Remicade or Cimzia, Humira, or Tysabri, and those are medicines that are either injected or infused on a regular basis to keep disease under control. And there's different, some of them go every other week, some of them are a monthly infusion, some of them are every 2-month infusion that we use. And these medicines, again, come with increased risk, and so there should be a discussion between the provider and the patient about which medicines are best for you. Always when you're thinking about medications for these type of diseases, we should make sure that the benefit of the medication outweighs the risk of the medication. Surgeries is something else that we use in IBD, and I would say surgery, we often want to say, does that mean we failed treatment? Well, that's not true. In a lot of patients with inflammatory bowel disease, we use surgery as an adjunct therapy. And a lot of times they can have a simple resection of their bowel, and that will kind of put the bowel back where it was prior, without any active disease. And then we start medications kind of with a clean slate. Surgeries nowadays can be much more easily tolerated because they're laparoscopic. They have little tiny incisions in the abdomen, usually 3 or 4 of them, and people will heal. They can be back to their regular activities within 3-4 weeks. Sometimes though things are more complicated, and sometimes people don't respond to any medications, and so we have to use surgery to actually remove the bowel. And the large colon, if that's removed, that's called an ostomy, and people will end up with the ileum, so it'll be an ileostomy, to their abdomen. And a lot of people live that way and function quite normally. People wouldn't know. There are very active people in the community that are athletes and lawyers and doctors and students, all with ileostomies or ostomies that you would never know that they have those things, and they function quite normally. And sometimes they have to take medicines afterwards, and sometimes they don't. I think some of the most important things that I really want IBD patients to remember, again, we talked about taking your medication regularly, but also making sure that you're taking care of other health issues. So along with IBD, you can get skin illnesses, you can get liver illnesses, you can get I said anemia, dehydration. So making sure that, one, you're eating a good diet. And what does that mean? Well, if you're going to McDonald's 3 times a day, you're probably not going to feel well. So eating raw fruits and vegetables as tolerated. And the CCFA has done a nice job about putting a diet online that actually gives you food lists to look at. And so eating fruits and vegetables is tolerated, lean meats is tolerated. Staying away from high caloric, high fat, and high sugar diets is probably a good idea. We know that those are benefit. Again, there's not data to suggest that, but we know people do better on those type of diets. Making sure that you take care of the rest of your body, so getting your exams through your primary care physician. If you're a female, you need to be into your gynecologist once a year and get your exams as they dictate. And making sure that if you're a man, you get in and get testicular exams and prostate exams. Bone density tests called a DEXA, D-E-X-A, that measures bone density. And we know in patients with inflammatory bowel disease that they have bone density loss with having disease. If they have to be on prednisone, that adds to their bone density loss. So getting a baseline exam, even if you're very young, to know where we're at, to evaluate your bone density is important. Skin exams are really important, especially if you're on azathioprine or biologic medication. And that's because skin cancer is an added risk if you're on these type of immune suppressive medications. So a good thorough skin exam through your primary care physician is also a good thing to do on a yearly basis. And then vaccinations, and that's really been pushed over the last couple of years. flu vaccine every day. And people that are on immune suppressive medications, so we talked about azathioprine, Imuran, biologic medications, should not get live vaccines. They have to be attenuated or dead vaccines, as we call them. So the flu mist, which is the nasal vaccine, is actually a live vaccine. And you should not have that if you're on those type of medicines. But you should talk this over with your primary care provider or your GI provider. They can help you with a list of recommended vaccinations. And then also, if you're a young female, pregnancy issues always come about. And does the having IBD going to make your baby have IBD? Not necessarily. We know there are genes that we've found that are associated with inflammatory bowel disease, but that doesn't mean that everybody passes them on to their children. But this is, again, a discussion that you should have with your GI provider. We do have lots of good data that's coming out on risk with pregnancy. We typically don't stop medications because we know they're safe. It's better to keep a healthy mom makes healthy babies. And we know that. We've had plenty of research data to show that, a lot of registry data. So that's important as well. I think one other thing that I'd like to touch on with patients is supplements. So what kind of supplements should you be taking if you have inflammatory bowel disease? I usually suggest a good multivitamin, and multivitamin, and you can take vitamin B and D and calcium and all this other stuff. But if you take a good prenatal vitamin, I promise you it will make you pregnant. Take a good prenatal vitamin. It has larger amounts of those things. And so for most of my patients, that's a good, simple, and less costly way to get the supplements that they need. Again, if you're taking prednisone, calcium and vitamin D are very important. The current recommendations are about 1,400 milligrams of calcium and about 2,000 international units of vitamin D. Again, you should talk with your primary care provider or your GI provider about these recommendations. Things like folic acid and flaxseed oil, those have been recommended. There's not a lot of great studies behind them. Folic acid in particular is important when you're taking sulfasalazine, but for the other medications, there's not a lot of data behind that. And then iron supplements if needed because you're anemic. If you're taking iron supplement and you're very anemic, actually they've found that vitamin C, 500 milligrams a day, actually helps the iron absorb. So that's important as well. And then if you're anemic, B12 or B6 vitamins may be important to take. Studies are available on all of these medications. So let's say you don't respond to any of the medications and you're worried about having surgery. I always suggest a second opinion, and we send a lot of our patients for a second opinion because there are studies available, and you may be a patient who responds to a different mechanism, and there may be a study available. And so ask you again, your GI provider will have that information for you that they can pass along. And then smoking cessation, real important. Smoking is equivalent to having about 20 milligrams of prednisone on board. And so it does not help your disease. We know that patients with ulcerative colitis can become more active when they quit smoking, but we also know that Crohn's disease, it's one of the things that prevent people from responding to treatment. So that's real important as well. And again, your provider can help you with information for smoking cessation. If you have concerns about changes in stool pattern, you've had bloody stools, abdominal pain that's lasted more than a couple days, you need to see your provider and get in and see if you need to be evaluated for inflammatory bowel disease. The most important thing is that people don't go months and years without being treated, because this is important to get this disease under control so that we can put you into remission and get you feeling well quickly. So if you have IBD, or you've had diarrhea, abdominal pain, or changes in your bowel habit, blood in your stool, please get in and get evaluated. We'll have on our website, DHS, you can find information and links to the medications that we talked about, to the CCFA website. And if you have concerns, get in with your provider so that you can be evaluated. Again, this is Betty White, ARNP, Digestive Health Specialist, talking about inflammatory bowel disease. Thank you.